So I'd like to introduce you to the third session where we're going to do some of that horizon scanning. And to kick us off, it's a great pleasure to introduce Professor Tom Denning, who is a Professor of Dementia Research at the University of Nottingham and also MindTech Theme Lead for Dementia, who's going to kick off talking about his connective assistive solution to Aspirations project, CASA.
You'll see from the first slide that it's a tripartite effort, and for some mysterious reason my other two collaborators are both indisposed today and unable to be here, but it is very much a joint effort, so I'm sorry that they're missing it. The other apology to make to you, not only Mike and Maria Laura are not here, but I'm not going to be here after I've given this talk, so I'll say cheerio to you shortly. So to say a little bit in general about dementia and technology, because we haven't talked very much about dementia during the course of today, are there things that are specific to dementia? What's distinct about dementia as opposed to developing technology that's suitable for older people in general? And indeed, what's different about older people and the rest of society anyway? So that it's always seemed to me that good design is good design, and we should use opportunities from other areas of technology to think about the groups that we're interested in. We need to be aware that not everyone with dementia is the same. They vary for a start in age from anything from about 40 to 120, and they cover all walks of life. So there is enormous heterogeneity. So when you're talking about dementia and technology, you're talking about a very mixed market. There's also dementia, as you know, is a progressive disorder, so you go from mild cognitive impairment, which I've abbreviated to MCI. You have a group of people with what's known as working age dementia, and their experience of technology will have been very different from people who are in their 80s or 90s now. And they're often living with younger families who have different experience of technology yet again. So it's a very mixed group of people. It's a large group of people as well. There's about 750,000 people with dementia and as many people involved in caring for them. So the sorts of areas that dementia tends to practice around are in this list here: encouraging daytime activity, company, continence, personal care, biofeedback, and there's probably lists of others. Some are about security and making sure that people are safe in their own homes, for example. And there is a couple of ways that one might look at technology. You might divide it into when it was invented, so first, second, third generation technology, and I've listed examples in red here. Or another form of classifying it that I don't claim authorship of, but is a useful way of looking at it, is technology that may be used by a person with dementia, that may be used with a person with dementia, and that may be used for a person with dementia. And if you look at those and think about it, then these kind of roughly correspond to the stage of dementia that the person might be at, although of course there's overlap. And often we talk about assistive technology in helping older people or helping people with dementia. It's a big industry, at least £150 million. There are a lot of devices on the market, 200 odd, and a lot of people providing services of one kind or another. We host through a voluntary organisation called Trent Dementia, which is based at the Institute of Mental Health, a web-based resource called AT Dementia, Assistive Technology Dementia. And that's quite an informative website that is of use both to professionals and to the public in terms of letting you know what's available, but also giving some guidance about technology for particular purposes. However, the market is characterised by there being little or no evaluation of almost anything. And so there's a need for a better assessment of available evidence and a better assessment of new products and so forth. And one of the things that's striking about assistive technology products for dementia is that it's a very product-based market. So the kind of archetype is that middle-aged son or daughter buys something for their aging parent that maybe is a white box with a red button on it they hang around their neck or something of that kind. And the person either uses it or they don't. Quite likely they don't use it. It goes into a drawer or into a garage or gets lost. And so the thing is a complete waste of time and of money. If you contrast that to the way that we buy, let's say, our broadband or our mobile connectivity, we actually buy into the service. So you have a kind of rental, don't you? And actually, after a while, you replace the device, or you get a new box, or you get sent an update or a new set of cables to wreck your house with. It's very much service-led, and it seems to me that particularly with the changing needs that you're going to have in the course of somebody having dementia, that this is a much more suitable model to have a service-led rather than a product-led economy. So this ought to change, really. And then you may know of technology that's appropriate, but uptake is poor. So how do you ensure that the people that need it most should get it? How do you ensure that stuff is available to people who are living in conditions of need, but not necessarily great material wealth, and do something about equity of access? And then one might also think about how people fund things beyond the obvious methods of either getting it through the public purse or buying it outright. So there may be other ways in which you can sort of buy subscriptions or use equity release to fund your access to assistive technology. So that's kind of the background. And I'll just tell you a little bit about a project that we've just finished, short project, 9 months, funded by the Technology Strategy Board. It arose out of a sandpit workshop that they held last year. Going on a sandpit workshop is a lifetime, an experience most people should go through in their lifetime at least once, probably just once. Rather intense week where you're kind of locked up with people who are partly collaborators and partly competitors. But anyway, we made a number of alliances in this particular exercise, and a number of projects were funded under the banner of the long-term care revolution, which was about trying to develop technologies that might help to reduce the pressure on people needing to go into care homes. So ours was called CASA, and the idea was around using assistive solutions, assistive technology, not designing our own so much as using solutions that are potentially available, but looking a little bit above the normal parapet of the sort of minimal standards of safety. So the aspirational bit is about what do people do in their spare time, what did they used to do, what do they want to do, and how might one put combinations of things together to make packages that make that work. And so we had two areas of it, two kind of user groups. One was older people with dementia, and another was younger people with learning disability. As I said, the idea was to link it to people's aspirations. You know, what are they passionate about? Is it gardening? Is it making, you know, is it preparing food? Is it about going to the opera? You know, how can you sort of really put things together and make stuff happen? And the methodology was to conduct tests of example packages and to start developing a business model for packages of this kind. So the partners in it were Leone Services. The lead had to be a small business. So my colleague Alexandra Evis was a finance person. Sensixa are a spin-off company of Imperial College. University of Nottingham, and we partnered up locally with the Alzheimer's Society to get access to carers for our focus groups, of which more later. University of the West of England, and Swiss Cottage School, which is a special needs school in North London with links to the chief investigator. So it was an interesting chemistry and kind of worked pretty well. So the structure of the project was it had 4 work packages. The first was about co-design. The second was about smart technology, particularly based around sensors, which is the interest of our partners at Imperial. The third package was about finance strategies and business model. And then the fourth was about designing pilot studies. So our interest in Nottingham was mainly around work package 1 and the co-design. And we did some thinking about needs and the relationship between needs and aspirations as to how you justify, in a kind of what might be a publicly funded model, talking about aspirations alongside needs. And it seemed to us that there's an argument for saying, well, actually, aspirations are in fact needs. You have a need to have aspirations, and you have a need to have your aspirations met. They're personal desires to achieve one or more needs. So they are in fact linked, not so much at the kind of level like this, but more at a level like that. And the meeting of both of these things is required in order to give you a sense of well-being and fulfillment in your life. So, for example, merely satisfying the needs does not necessarily bring about well-being. So that if you can eat, if you're hungry, you can eat food that's entirely that kind of keeps you alive, but is entirely unsatisfactory experience. Or you can come to the Royal College of Physicians and eat surrounded by oil paintings of distinguished physicians in great comfort, networking with people who are like-minded. So you can have a much greater quality experience, and the quality of the experience is as important as satisfying the need, I think. So what do we actually do? We as I say, it's a short project, nine months from start to finish, including all the writing up of reports and so forth. So we had 2 rounds of interviews with Alzheimer's Society carers. The first was with some small focus groups around their current use of technology and looking particularly for tasks where aspirations might be important. And then having done that, we went back for a second round of interviews with some of the same carers, but also some new ones. We did these on an individual basis rather than in groups. Where we developed a brochure around a chosen task or chosen area of aspiration, if you like, that might assist the person, and ask them to look at how this appealed to them in terms of acceptability, feasibility, and affordability. So they were kind of. So the first was gathering some empirical data. The second one was, if you like, a kind of thought experiment. So an example would be about getting food that you want, having meals that you enjoy, a perfectly reasonable aspiration. So that in order to do that, you've got to source the food. However you get that, you might go out for it, or it might be delivered to you. You have to select what food you're going to prepare, and then you actually have to do it without burning the house down. And so we developed, as I say, a set of brochures around packages that might help with each of these tasks. So in short, the discussions with dementia carers came out with 3 main themes. So the first was about the carers' general feelings about dementia. The second was around stigma and its relationship to design and technology. And the third was about technology for independence. I'll just say a little bit more about those. So carers are crucial. They support the choice and the use of new tools for a person with dementia, but they can also obstruct or prevent the use of assistive technologies. They may worry that the thing is unsafe or the thing is too complicated. And it was clear from the spread of people that we met that there were generational issues in the way that technology is used in the house at the moment, varying from somebody of working age who was using a sat-nav and still driving, you'll be pleased to know, and other people where it was the parents of the carer, and they just about had a smoke alarm and an automatic kettle, and that was the limit of the technology. Human prompting was considered to be more important than assistive technologies in general, and both the caregivers and for people with dementia, the loss of independence is a really important issue. And this might be summarised by the carer's view of they are the main assistive technology, and I think I would probably agree with them. Certainly you can't do assistive technology for people with dementia without engaging with family carers. So the second theme was about stigma, as I've mentioned, so that if you have a thing that looks like looks like a medical technology, that it's ugly, unattractive, it's got a big red button in the middle of your chest, then you may well not choose to wear it. I probably wouldn't. This is a name badge, and that's a microphone, but I haven't got a buzzer on me. So wearable tools can be a problem. So for people with dementia, preserving their privacy was more important than their safety, whereas maybe for the carers it might be the other way around. And certainly carers can become embarrassed if the behaviour of the person is difficult. So stigma. So in thinking about what you would put together, what you would design for people with dementia, you need to be thinking hard about what's stigmatising. So good design for everybody is good design for people with dementia. And so a quote on this, I won't read this out, but basically you don't want to be labelled as somebody having a disease as you're walking down the street. Why would you? You know, diabetics don't do it. People with skin cancer don't do it. You know, I mean, you just don't. So then technology for independence, the carers tended to gravitate towards tools that made things safer. There was a lot of interest in things that are entertaining. And some of the conversations I've had today have been about things that are entertaining. And low technology is, as long as it works, is probably more appropriate than being too smart with it. I won't read that out. So in summary, we had three main themes, and I think I've made all those points already. So what do we want to do next on top of the data? Having tested our brochures, we've now designed a set of personas that describe carers of people with dementia in terms of their individual profile and the aspirations. And the idea then is to move on to develop enabler packs. And the next meeting about the next round of funding for long-term care revolution is just down the road tomorrow, as it happens. So, and these are what personas look like. So you've got boxes at the bottom about aspirations and a certain amount of relevant stuff about the background information of the person, which again you co-develop with them. So our next project is a collaboration with some Norwegian researchers and a private company funded by the Research Council of Norway, which will be a mapping tool that basically aims to put people with dementia and their carers in touch with technology that may support their activities. So it seems like a really good follow-on from what we've already been doing. So a number of people were involved in the study, and I've listed their names, and many thanks to them and to the TSB, who are now, of course, Innovate UK, and also Lynn was the kind of TSB minder throughout the project. And thank you very much indeed.
Good afternoon. Thank you for coming here to hear about this. Something slightly different from the previous sessions, because this is very much at the very early stages of development. And people who, in hearing voices in schizophrenia and other psychotic conditions is very common, and about 25% of people who hear the voices continue to hear those voices despite everything that we currently throw at them, including clozapine and psychological therapies alone or in combination. So it's a real sort of enduring clinical challenge. But it's well known that people who engage with their voices and attempt to have dialogue with them in general have better outcomes than those who deny or try to shut down the hearing of the voices. Active avoidance seems to make matters worse. And case examples from so-called trialogue therapy have been written up with some success. This is a therapy widely used in psychological therapies where there's a therapist, the patient, and an empty chair. And the idea is the patient puts their voice entity into the empty chair, and one attempts to create a dialogue with this. And Julian Leff, a friend and colleague, some years ago, thought, why don't we take this a stage further? One of the things that we do when we're talking to someone is we look them in the face. We have a facial contact. And he developed a form of therapy which uses a computer simulation of the entity that the person imagines is talking to them or hears talking to them. And he did this over a 6-session dialogue therapy. This is the setup. I think I've got a pointer here. Show you the setup. So the setup is a 2-room setup. So in one room is the clinician who sits in front of a TV monitor with some fancy software that can switch between his own voice and the morphed voice to approximate to the voice the patient hears, while the patient sits in a separate room and has a dialogue with the morphed voice and the computerized entity. So the clinician can then interrupt it periodically and give advice, commands, suggestions of how to adapt the therapy, how to adapt to the voice. And essentially it moves the voice from being persecutory towards being supportive. And there's a panic button facility. Should it all get too heavy, someone can press and escape. And he developed this study and carried out a very small randomized trial with a crossover. It ended up with just 16 patients receiving the therapy as against 12 who didn't. And he had some extraordinary results. These were all people who had heard their voices, despite adequate treatment, for more than 10 years. And he had 2 people completely stopped hearing voices after 2 sessions of this, and a third who stopped after 5 sessions. That was really very striking, and he's written this study up, and he's talked about it in a number of places. Other significant changes, he had great reductions in self-reported ratings of malevolence. Very, very quickly, because this is not really about the research today, it's more about the technology, but we're trying to do 142 people randomized to receive either the avatar therapy developed from Julian's work or a control therapy of supportive counseling. And we have a primary outcome of the total number of score on the CIRATs, which is a measure of the frequency and intensity of the voice hearing experience. But we're also measuring depression, social function, quality of life, and a health economic outcome. What's it look like to create an avatar? This is our current system in its evolved state. And we start by creating, with the service user, the simulacrum of the voice they hear. And we start with this default, which is a recording of the therapist, which is made independently and separately and on the computer file, reading a set of transcripts from paragraphs that catch our intonation and our particular way of speaking. And these bubbles here are all morph transforms of that speech sample. So the ones here are getting progressively more masculine, the ones here are getting progressively more female. So it's possible, for instance, for me here to be turned into a young female, which is quite a feat of entity. The face there is not used in this part of the therapy. But the patient, basically, one says, describe the voice. It's a male voice. Yes, it's a voice deeper than mine. Yes, it's much deeper than yours. So you might take 09, pull it up to here, play it, say, yeah, that's a pretty good match. And then there are these sliders that you can fine-tune the voice. Jumping ahead of myself, we're getting between 70 and 90% match to what the person reports hearing in their ordinary voice hearing experience with this technology. Having created the voice, we then move on to create the face, and this is a little video clip. Can someone make it?
Okay, so this is the face that we're going to start with. Is there any way in which we could change it to make it closer to the face that you're looking for?
The hair looks a bit thin. Like, is there a way of making it kind of thicker and darker?
Okay, well, I'm going to show you a hairstyle which I think might be what you're talking about, and then you can tell me if that works for you.
This is software.
Okay, let's just see what you think about this.
Oh yeah, no, that's more like it, like kind of thick and dark.
Okay,
yeah.
So you're happy with the hair? That's kind of matching what you want.
Yeah.
Anything else that we could try to do to make it closer?
Could we make him like look a bit older, maybe?
Okay, well I can do that here. Let me show you what this face would look like if he was made older, which is what I'm going to do with this slider here. You see the face is kind of aging.
Yeah, yeah.
So maybe if I bring it back a little bit and you tell me when you think it's about right in terms of the age. So I'll bring it back very slowly.
I think about there, yeah, like quite old.
Okay,
yeah.
so that's sort of saying it's somebody in their 50s.
You're all quite old, or most of you are all
that's
quite old.
Brilliant. Anything else that you'd like us to try to do with the face?
It's like he hasn't really been shaving or hasn't washed, so can you make him look a bit like stubbly or like he's got a beard?
Okay, we can do that. Let's just have a little go with that. Just have to let me have a little look. So here we go. So I'm just going to change the sort of slightly a bit more sort of stubble. So that's just getting a little bit more.
Yeah.
How does that look?
That looks good.
Okay, brilliant. So, so happy with what we've got there?
Yeah.
Okay, fantastic. Thank you very much.
Okay, so that's the creation of the face that matches the voice. And face, it's very interesting because when Julian did this work, all his people had faces they could readily identify. We're now working with a much broader spectrum of diagnoses. We're working, or a much narrower spectrum of diagnoses actually. We're looking at people who have schizophrenia or depressive psychosis, so quite a narrow range of mainstream psychotic disorders. And interestingly, most people are saying, well, not most, about a third say we don't know who we're talking to. We don't see them. We don't know who it is. So we, in that case, say, well, pick a face from this list of faces that you're comfortable working with. Everyone knows what voice they're hearing, but the face is much more varied. The other thing, look at some of Julian's early talks. The faces are really quite horrific. Our experiences, they're not horrific at all. They're faces like yours and mine that people are reporting. A few horrific ones, a few clowns, a few extraordinary people, but of the 70-odd people we have now worked with, they're in the minority. Most are picking faces that you would not be surprised to see in this room. These are another couple of faces. This just shows you the setup. So this side here is the screen that the therapist uses with two slider controls just for your own volume, therapist audio, client audio. And this is the control. If you're speaking to the client in your own voice, then you press that switch and talk. If you want to talk to it in the morphed voice of the avatar, you press that switch and talk. And it's lip-synced and eye movement coordinated. So it looks like you're talking, and it's semi-3D. It looks like you're talking to a talking head when you're actually playing it in the room. And what's it look like? Well, session 0, which is our first session, is we now provide 6 sessions of therapy and 1 session of setup. So session 0 is our setup session. We aim to try and get a 70%, minimum 70% match on voice and face, if there is a face. Very, very important that we use the real words that the patients actually report hearing. So if they're unsure in the first session, we ask them to keep a diary over the course of a week and jot down anything the voice actually says. Most of these statements are quite short. They're short statements that then have tremendous meaning for the individual. So on average, about 6 or 7 words per statement, something like you're a fool, idiot, buffoon. You'll see some of these later on. But those are actually where we start the session with exactly what the person says they hear, however horrific it may be. And then we try to explore in that session any belief flexibility. Is there any chance this could be your own thoughts? Is it definitely from somewhere outside? If there is belief flexibility, and a chap I've just finished working with had quite a strong degree of the belief flexibility, so we were able to use this very effectively in therapy to say, look, I'm only the bad things you think about yourself. It's a very useful kind of hook in therapy. So we're looking for the key beliefs about the identity, power, and the intention of the voice. We're looking for how past trauma, childhood trauma, abuse, bullying at school may have formed or may contribute to the voice hearing experience. And self-esteem is turning out to be a hugely important issue. I would say 2/3 of the people we're working with have low self-esteem that comes out of prior traumatic experiences. So we have to include in the therapy some very rapid self-esteem work. This is the therapy structure over the 6 sessions. Session 1, basically warning the person it's going to be immensely stressful, giving them a session that is the real voice content, unmodified, or exactly as they hear it and paced as they hear it, with a practice of assertive statements back to the voice. What we want to end up with at session 1 is somebody feeling they've been able to tell the voice where to get off and leave them alone in a firm, assertive way. Or if they have a habitual style of shouting excessively, then to take a more mindfulness approach, to be rather more detached from the emotional content of the voice. And so when it's playing with the first session, depending what you found and what you estimated in your initial assessment, and then over the 6 sessions, gradually shifting this incredibly hostile, angry, typical voice more into a dialogue. So the session then expands into much more of a 2-way conversation or a 3-way conversation. And the kind of extra element in this stuff is therapist has to get into the mind not only of the patient, but of the avatar. What would this avatar be like if it was beginning to transition? Why would it transition? What would make the avatar that's normally critical less critical? And this is where sometimes self-esteem work comes in, that one may be doing quite a lot of work with the client to talk to the avatar about their own strengths and benefits, and then getting the avatar to respond accordingly, and then a final session which is just winding up at 6 sessions. Play this one for me now. This will just give you a brief snapshot of a session 1.
Are you ready, Owen? Good stuff.
Therapist there, Tom Ward.
You're worthless. You're a waste of space. Owen, I want you to talk back to the avatar as strongly as you can.
Stop it.
You're worthless. You're a waste of space. Your life's going nowhere.
Stop saying those things.
You're nothing.
Leave me alone. Stop that.
Owen, that's really good. I want you to be as strong and powerful as you can.
So you don't think it's right you're worthless?
No, it's not true. I'm not worthless, and I don't have to listen to you saying that.
What's good about you?
There's lots of good things about me. I don't have to listen to you saying I'm worthless. I'm a good person, and the things you're saying aren't true.
Tell me one good thing that you've done this week.
I did the shopping for my mum. That's a good thing to do.
That's really good, Owen. You keep going telling them the good things that you've done.
I've come here to do this, to speak to you. I've been going to my exercise group. I've done a lot of good things, and it's not fair you saying that I'm worthless.
I can say I may have misjudged you. You're stronger than I thought. But I'm not giving up that easily. You've given me some things to think about, Lee.
So that's what the setup looks like at the moment. And immediately you see that we have a problem. It's 2 desktop computers that are linked by wires, which means drilling holes in the walls of the NHS clinic. Can this thing be done on the NHS Ethernet? Very simply. It runs on the university Ethernet without any problem. So I think it was it Sean this morning who pointed out the real challenge of getting any of this stuff into the NHS. We're still trying to negotiate access through the trust Ethernet to be able to run the. Can it run by wireless? Yes, it can run by wireless. But again, can we get this to function? The next issue is a whole issue of stability of the system. This is all very, very new stuff. This is very new equipment. And in the early days, it frequently hung and frequently distorted the sound. That's pretty much problem solved now. Moving away from wireless and desktops, running in NHS facilities, simplifying the creation of the avatar. I showed you a little snippet there. It takes about 45 minutes to create an avatar. It took us, me and Tom, a good 2 days to learn how to operate the software smoothly enough that you weren't being very clunky. What we're moving to is wanting to get a system that any jobbing clinician could be able to run in their office on a desk without that clunkiness. And so we're working with a design company to greatly streamline what is still a very experimental system at the moment. Maybe trying to pick it off easy point-and-click menus rather than that rather cumbersome system we've got. Improving the look and feel. And is there anything we can do about the therapist voice and role? At the moment, we have to go to a speech lab, record our voices in order to include them in the therapy. There is no reason why we can't do that just on the same computers, and that's something we're working on as well. I'm probably out of time. I'll just give you a couple of very small clinical snippets of people we worked with. We are not having quite as spectacular results as Julian, but we've had 2 people who completely lost their voices in under 6 sessions. We're doing a follow-up at 3 months and at 6 months. I don't know whether these 2 guys will retain the absence of their voices, but it's very interesting. One was a man who I had known previously clinically 10 years ago, and who has been in and out of forensic settings most of his adult life, and had the same persistent auditory hallucinations that when I first assessed him more than 10 years ago. And the voices that he had came from a Brixton street gang, and the voices were around the peddling and the use of drugs. And what I had to do as the avatar was play a South London Jamaican street gang. Now, I have an advantage. Some of you may know, some of you don't know. I was born and grew up in Jamaica till my mid-20s. So I can talk like that if I need to talk it. So I did this with the avatar. He was completely convinced that this was his even though he'd signed the thing and it said it was Tom Craig, is mimicking the voice, in session, which is what happens to any of that play computer games, in session, he was talking to his street gang guy. And we negotiated. The street gang guy said to him, you really don't need to do these drugs anymore. We're going to say you don't need to sell them on the streets anymore. You should give them up yourself anyway because they're not very good for you. Words to that effect. And in any case, I'm going back to Jamaica because I've got a new girlfriend and she's in Jamaica. And he ended up with this tremendous discourse with the avatar in which they were the best of buddies. And he said, well, goodbye. I'm really, I'm pleased to hear you're going because you won't trouble me anymore. But I wish you well. And he stopped hearing voices at the end of that session and has remained, as far as I know, subsequently. So it's a treatment, I think, with legs, as they say, but a tremendously long way to go before it's anything that's practically useful. Thank you.
And I wanted to move immediately on to our last speaker in this session and to welcome Andrew Jackson from ProReal, who's also going to talk to us about their view of avatars.
Thank you.
Andrew,
thank you, David. And thank you, Tom. Follow that. I run a small company. The other colleagues of mine are in the audience somewhere, and this presentation is on behalf of them for the work they've put in over the last 12 months. And it's also a huge thanks to Chris for inviting me to speak here. I'd like to do a couple of things. One is to describe to you what this software is about. For anyone like me who was completely captivated by that speaking voice and that avatar, that immersive, that immersion, that sense of presence and flow that we get from avatars and from immersive technology is really valuable in the treatment of mental health conditions. So I hope to tell you a little bit about that, tell you where we're up to in our research, where we want to go next, and also just give you some perspectives from a small company looking into this world as a new boy on the block, and what we see about evidence and what we think, just to spark the discussion that was framed by Chris this morning. I'll start with, I know somebody on Twitter is counting the number of times somebody uses the word service user. So please, can you hold my hand up if I succumb? This is the story of a real person, although we've changed her name. I'll call her Maya. She's 12 years old, and I want to just tell you some of her experiences using our software, which will help you understand what it is that we do. The software was introduced to her after many, many sessions in therapy of various types, and after something like 28 sessions of another type of therapy, really a very complex case with Maya had quite a difficult childhood, abusive and quite a toxic childhood, really, with attachment issues with both parents, and that led to a diagnosis of something called oppositional defiant disorder when she was about 11 years old. So this is what she was introduced to, with the instruction of just see what comes up in this landscape. That was the only instruction she was given. She put an avatar into the world, choosing a dark place, and she started to label that avatar. She called it she. And she gave the avatar a size and a color. And then through one of the features we've got, selected a posture and went to something called beating up. And just experienced what it was like looking at this avatar called she, beating up. She introduced her own avatar called the me avatar and selected a posture of being beaten up and just sat and watched. And that was session 1. And in session 2, the system saves what she's done, and she came back to the same session, and she just experimented with what it was like to stop the she avatar from beating up. So adopting a neutral posture, but with the me avatar still cowering from the blows that weren't coming. And in session 3, explored what it might be like to be the same size as that she avatar, with none of the violent postures. That was quick. So there we go, just 3 sessions. I think we're on session 7 or 8 now, with some great results. Okay, so that's one case. We wanted some a wider and a broader evidence set. Just let me tell you a little bit about what the software does and how it works. It introduces the idea of a 3-dimensional landscape in which to set the narrative, and that landscape itself has some symbols and can use metaphor to help with emotional expression. The avatars, as you've seen, have postures, and they can be labelled. They can be labelled with speeches, thoughts, and that, together with the postures, provides quite a powerful platform to help somebody put their thoughts or their feelings into pictures. And that's modifiable and savable. And as I mentioned, we have props. We've got a few symbols. There, a key, a road closure sign, a bomb, a fire, a gravestone. Different symbols that can help to help somebody think this thing through in a different way. And we have cameras that can look at this situation either through the eyes of one avatar or from a different perspective. So again, just helping the thinking process. We were really lucky and pleased to be awarded the first phase of a feasibility study funding from the Small Business Research Initiative, and it helped us do our really first experiment with how the software works and get our first evidence base, if you like. We conducted it in a prison because we couldn't think of a harder place to go, and we had an intervention based on 6 sessions of 1 hour duration, using the software in a therapeutic community in one of Her Majesty's prisons. And we were really pleased to be working with the University of Roehampton and Metanoia Institute, who carried out the research for us. I won't go into detail, but the headlines, we had a sample of 6 participants only, so this is really small and not sufficient to give any statistical significance to the results, so I will use some words here, really. There were some preliminary indications that it did have an impact on psychological distress. More importantly to us, and actually really we were greatly heartened by this data, was the qualitative information we got from all the interviews and the post-discussions, which participants talked about new insights. I think Sarah mentioned aha moments earlier on in her discussion. They got some of those, and they worked with them, and they developed empathy both within and in relationships outside of the prison. So we were really very, very encouraged by that information and by that data. And it is a new technology, but fortunately it stood up. It was usable. It was rated quite highly by the residents. And we also learned a tremendous amount about how difficult it is, as Tom was talking earlier on about getting technology into a secure environment, how difficult that is and what the challenges were. So that's where we've got to, and where we go to next is working with young people. Subject to signing contracts, which I'm sure we'll do. We've been awarded the 2nd phase of that research, and we really want to start working with young people with very early intervention work. We hope to conduct research which will show us several things. Does it produce a positive therapeutic outcome? Is it acceptable to young people in its current form? And if not, what do we need to change? We absolutely want to involve young people in its redesign, and we've got a significant amount of change that needs doing to the software. We need to think hard about the context as well, because we learned so much in the prison about if we were going to do that again, how we would tackle that. But the context matter. It matters if it's in a clinic, it matters if it's in someone's home, it matters if it's in a hospital, it matters absolutely. So we've got to think hard about that and fund some technology changes which will make it work in different situations. And we want to make sure it's going to stack up financially for the NHS and for any other institutions that we use this within. So we've got to do some important work on healthcare economics. And the technology we want to build may look something like that on a tablet being used in a home. I can see David looking at me, so I'm going to just quickly scan through now. Is this how we're doing for time? Okay, all right. A perspective on this question of mind the gap and the evidence base. And I thought I'd just share something from, I suppose, some of the work. Many of you will have seen this Gartner hype curve thinking about adoption of technology. If I can think about this, I went back to that question of what do we mean by evidence, and interestingly in the definition, that idea of current best will never, as technology develops, really get to a stage where we're confident with the evidence base. We'll only ever be able to use current best, because that's the nature of the speed at which technology is changing. So I thought I'd just share the one model that we've come across and are using, this idea of 4 sources of information that help us build evidence. One, yes, we absolutely want our gold standard of randomized controlled trials, and I hope maybe next year we'll be standing up speaking about that, but we're not there yet. So we have to really look at all sources of evaluation that we have. I think the people that use the software provide really valuable evidence, and we certainly learnt that in the prison, and we've learnt that with the work we've done with young people, and it sometimes can't be measured, and it sometimes isn't quantifiable in an academic report, but we can certainly see it, and it shapes our direction. And the staff and the stakeholders' perspectives are really important too, because ignore those at our peril, as we heard earlier. The biggest barrier that we found is clinician adoption and that doubt. So unless we listen hard and understand that and work with that, we are kidding ourselves. But finally, that concept about context and where it is, in what organization, what are the data requirements, what are the security standards, what are the confidentiality issues, what size is the room, how well will a network work. So all of those, for us, we think of evidence as broader than randomized controlled trials. We need those. I'll leave you with one thought. And I haven't mentioned service user yet, I hope. This is from a guy who was in the prison, and it was one of many quotes that just really almost brought tears to our eyes in the team that had put a lot of work into this. And I'll just let you read it, because for us it said a lot. Thank you very much.